नमस्ते बिटिया, हमेशा खुश रहो बिटिया। I am Dr. Bharat Sharma, Assistant Professor, Department of Pathology, Faculty of Homeopathic Science, JAYOTI VIDYAPEETH Women's University, Jaipur. Today's topic is infective and other enterocolitis. Now, enterocolitis is an inflammation of the digestive tract involving enteritis of the small intestine and colitis of the colon. Common medical, common clinical manifestation of enterocolitis are frequent diarrheal defecations with or without nausea, vomiting, abdominal pain, fever, chills, alteration of general condition. General manifestations are given by the dissemination of the infectious agent or its toxins throughout the body, or most frequently by significant losses of water and minerals, the consequences of diarrhea and vomiting. Besides inflammatory bowel disease, a variety of other acute and chronic inflammatory conditions affect small bowels or large bowels or both, the last named being more common, which is enterocolitis. Enteritis and colitis both easily affected and rarely seen alone affected. Hence, all these conditions involving small bowel and or large bowel are described together here for better correlation of features. The various forms of inflammations of the bowel after excluding inflammatory bowel disease can be categorized broadly into infective enterocolitis and pseudomembranous enterocolitis. First, infective enterocolitis. These are a group of acute and chronic inflammatory lesions of small intestine and or colon caused by microorganisms, either by bacteria, by virus, by fungi, by protozoa, or by helminthes. All these are characterized by diarrheal syndromes. Pathogenetically speaking, these microorganisms can cause enterocolitis by two mechanisms: by enteroinvasion bacteria producing ulcerative lesions, and by enterotoxins producing bacteria resulting in non-ulcerative lesions. So first is enteroinvasive bacteria or enterotoxins produced by bacteria. Common microorganisms producing enterocolitis are bacterial enterocolitis, viral enterocolitis, fungal enterocolitis, and protozoal and metazoal infestations causing enterocolitis. First is bacterial enterocolitis and its causative bacteria. First is enteroinvasive bacteria. Examples are tuberculosis, Salmonella, Campylobacter jejuni, Shigella, Escherichia coli, and Yersinia enterocolitica. Second is enterotoxin producing bacteria. Examples are Vibrio cholerae. Fungal enterocolitis is caused by either candidiasis or mucormycosis. Now, protozoal and metazoal infestations. It can be occur by either Giardia lumbelia, Ant amoeba histolytica, Ballantidium coli, Tinea solium, Ascaris lumbricoides, Ankylostoma duodenale, or Strongylidia stericularis. Now, pseudomembranous colitis. Pseudomembranous colitis or PMC is a toxin-mediated enteric disease caused by Clostridium difficile. Now we are going to discuss little bit about Clostridium difficile. It survives well in nature and is widely distributed in the environment. It can be cultured from stool in 5% of healthy adults, 10 to 30% of symptomatic hospital and nursing home patients, and 30 to 50% of healthy infants. Therefore, the mere presence of C. difficile does not necessarily indicate disease. Now, incidence of antibiotic-associated diarrhea varies from 5 to 39% depending on the antibiotic type. Pseudomembranous colitis complicates 10% of the cases of antibiotic-associated diarrhea. C. difficile is found in the stool of 15 to 25% of asymptomatic antibiotic treated or hospitalized adults. Most of the pseudomembranous colitis over the last 3 decades have occurred in association with antimicrobial therapy. Nearly all antimicrobial agents have been implicated in causing pseudomembranous colitis. Most frequent associated antimicrobial are clindamycin, cephalosporins, and penicillins. Now, risk factors of pseudomembranous colitis. First and most common is advanced age. Second is hospitalization. Third is inflammatory bowel disease. Fifth is chemotherapy. And sixth is immunosuppression. Pseudomembranous colitis clinical presentation. Watery diarrhea with as many as 15 to 30 stools per day. Second is abdominal pain or cramps. Often have lower quadrant tenderness in association with fever and leukocytosis. Third is fever, either absent or low grade or quite high. Oligoarticular, asymmetric, large joint arthropathy is also seen in the patient of pseudomembranous colitis, but most common are gastrointestinal symptoms in which the most commonest are watery diarrhea or vomiting. Here is an image of pseudomembranous enterocolitis. The mucosal surface of the colon seen here is hyperemic and is partially covered by a yellow-green exudate, which can be seen here. The mucosa itself is not eroded. Broad-spectrum antibiotic uses such as clindamycin and or immunosuppression allows overgrowth of bacteria such as Clostridium difficile. Pseudomembranous colitis pathophysiology. Disruption of the normal bacterial flora of the colon, colonization with C. difficile, release of toxins by C. difficile, and mucosal damage and inflammation. Now, medical treatment of pseudomembranous colitis. In mild or moderate cases, supportive therapy alone is sufficient. This includes discontinuing or changing the offending antibiotics, avoiding necrotics and antidiarrheal agents, maintaining fluids and electrolyte intact, and enteric isolation. Most patients, about 75% of symptomatic patients and 25% patients with colitis, will experience complete recovery within 10 days. In fulminant or intractable cases, hospitalization for IV hydration will be necessary. This session is powered by Digital Version 2.0 Jyoti Vidyapeeth Women's University. I hope you all enjoy this session. If you have any query, please mention it in comment box. Thank you.